When we talk about the hip joint, we cannot ignore its nerve supply. After all, nerves are not only responsible for movement and muscle control, but also for sensation and pain patterns. And in the hip, these patterns can be tricky because pain is often referred to distant locations, like the knee. The lumbosacral plexus. The hip is innervated by the lumbosacral plexus, which is formed from the T12 to S4 nerve roots. This plexus lies posterior to the psoas muscle and branches out like a highway system, sending nerves to the anterior, medial, and posterior compartments of the thigh. Posterior division. From the posterior division, we get some very important nerves. The sciatic nerve. This is the largest nerve in the body and is actually a combination of two divisions, the peroneal or lateral and the tibial or medial. Clinically, this is the most commonly injured neural structure during total hip arthroplasty, THA, especially with the posterior approach. Why? Because the sciatic nerve runs deep to the long head of the biceps femoris, very close to the operative field. Injury here can cause devastating deficits like foot drop. The superior gluteal nerve supplies the gluteus medius, gluteus minimus, and tensor fascia lata muscles. These muscles are critical for pelvic stability during walking. If this nerve is damaged, the patient develops a Trendelenburg gait. The hip drops on the opposite side when standing on one leg. The inferior gluteal nerve supplies the gluteus maximus, the main extensor of the hip, crucial for climbing stairs or rising from a seated position. Posterior femoral cutaneous nerve provides sensation to the posterior thigh. Anterior division. From the anterior division, we get the tibial nerve, the medial part of the sciatic, controlling posterior thigh and most of the posterior leg muscles. Nerve to quadratus femoris and nerve to obturator internus, small but important branches that help control the deep external rotators of the hip. Pudendal nerve, which exits and re-enters the pelvis, innervating the perineum. Coccygeus nerves, supplying the coccygeus muscle. The obturator nerve, one of the most clinically important nerves for the hip joint. It innervates the medial compartment of the thigh, all the adductors except the hamstring portion of the adductor magnus. Because of its articular branches to the hip joint, irritation here can cause referred pain to the knee. This is why a patient with hip arthritis sometimes comes to the clinic complaining of knee pain, even when the knee is perfectly normal. The femoral nerve. The femoral nerve runs between the iliacus and psoas muscles. It gives off branches not only to the quadriceps, but also to the skin and to the hip joint itself. Clinically, it's at risk during anterior approaches to the hip or with retraction in pelvic surgery. Sensory branches. Two smaller nerves deserve mention. The lateral femoral cutaneous nerve, derived from L2-L3, this nerve runs deep to the inguinal ligament near the ASIS. It's vulnerable during anterior approaches, particularly the direct anterior approach to THA. Injury here causes meralgia paresthetica, burning pain or numbness over the outer thigh. The genitofemoral nerve, from L1, L2, splitting into a femoral and a genital branch. It pierces the psoas and runs along its surface. It's a small nerve, but important to know during retroperitoneal and pelvic surgeries. Practical clinical pearls. The sciatic nerve is the most commonly injured nerve during THA, especially with posterior approaches. The superior gluteal nerve injury results in Trendelenburg gait. The obturator nerve influences medial thigh motor function and referred hip to knee pain. The lateral femoral cutaneous nerve is particularly vulnerable during anterior approaches, so remember the risk of meralgia paresthetica. Always remember, hip pain can be felt in the knee because of shared innervation. So, the neurological anatomy of the hip is not just an academic list of nerves. It explains surgical risks, post-op complications, and even why patients often feel pain far away from the hip itself.